Welcome to the American Shoulder and Elbow Surgeons Podcast. I am Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Doing well, Peter. Thank you. Thanks for having me. How are you?
Doing great. I should first mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the University of Colorado. Today, we are very lucky to be joined by a special guest, Dr. Bill Mallon, editor of the Journal of Shoulder and Elbow Surgery. Dr. Mallon is well known to most members of our society through his role as editor, but for those of you who don't know him well, I'll review his background briefly. Remarkably, Dr. Mallon is the first person interviewed on the podcast with his own Wikipedia page, so you can look him up there. Dr. Mallon attended Duke at college, where he graduated magna cum laude in degrees in both math and physics while playing varsity golf, and while also being a two-time All-American and a two-time participant in the NCAA tournament. During that time, he won over 40 tournaments and several championships, and he then turned pro and joined the PGA Tour, posting multiple top 10 finishes, playing in the U.S. Open, and being ranked in the top 100 multiple times. He then returned to Duke for medical school and residency and had an illustrious medical career, including many publications, many roles in the ASES, including a past presidency, and a role as editor for the Journal of Shoulder and Elbow Surgery, which he has had for a decade at this point. In addition, he's a leading authority on the history of the Olympic Games and has written over 24 books, for which he was awarded the Olympic Order in Silver in 2001. So truly an incredible career in 3 different areas, which is just incredible.
It's really remarkable. Dr. Mallon, welcome to the podcast. Thanks so much for joining us today.
Thanks for having me, Rachel. Look forward to it.
Well, why don't we get started with this podcast? Can you give us a brief synopsis of how JSES has changed during your tenure as editor-in-chief? Some specifics, but really you can take this wherever you'd like. How have the number of submissions changed? How's the acceptance rate changed? What have you seen over this last decade?
Well, when I started, which was, I was chosen as the next editor in April of 2008. In 2008, Bob Neviser, the previous editor, had 480 submitted articles for the year, and they published 6 issues a year. This year, we're going to have just a little under 1,500 articles submitted. We'll publish 13 issues, and we have a subsidiary journal, JSES Open Access, which is about to become JSES International, that publishes another 4 issues. So we now publish 17 issues, and we receive about 3 times as many submitted articles as when I started.
You know, it's really unbelievable. I'm just going to ask a question related to that. With the introduction of the open access journals, which have become much more popular over the last several years, there are also some thoughts, in terms of author submission fees and whatnot in terms of getting papers published. What are your thoughts as to the most positive aspect of the open access journals, and why did you decide to take that direction as one of the offshoots of JSES?
Well, we almost had to take that direction. There's a movement afoot that started in England and Europe that all scientific publications should be open access, so anyone can read them whenever they want to, that they shouldn't be only subscription-based. The movement at its most extreme says it should not only be open access, but there should be no author fees to publish. But, given that there's no way to get a publishing company to actually be involved with something like that. So we sort of had to go to open access with author fees. We do not charge a fee for submission like JBJS and other journals do, but we do, if you publish it, charge a fee. One of the good things about this for authors is the papers are read more widely. They're seen by more people, and it can actually increase your personal impact factor, which is, there's several different metrics like that. The most famous one is called the H index, where you can look up, say Rachel Frank or Peter Chalmers, and see how many times they've been published and how widely their publications have been referenced in other articles. Well, when more people are reading your articles in open access, there's more chance that they'll reference them, which will increase your H index or any of the similar metrics.
Certainly, it seems like removing barriers for readers to be able to access the articles could only be good. What when you think about the articles that have been published, and I'm sure there's so many of them, what has been your favorite one over the past decade and why?
My favorite one that we've published since I've been editor was an article in which Paul Sethi was the senior author, and he was really the first surgeon who came up with the idea to use benzoyl peroxide to sanitize the skin before surgery to try and prevent Cutibacterium acnes infections. We actually got some publicity in the national media for that, which I used to jokingly call the Clearasil paper, because benzoyl peroxide is the most active ingredient in Clearasil or other acne medications. I think that's changed the way we practice. I no longer practice because the job has gotten so busy, but if I was practicing, I would definitely use benzoyl peroxide or maybe H2O2, which is the active ingredient in the benzoyl peroxide, for all my patients, especially with arthroplasty. And this has been confirmed now in a lot of other papers that have come out. There's been one or two that haven't confirmed it, but by and large, it looks like some form of using a benzoyl peroxide or active H2O2 can decrease the C. acnes load on the skin before you make the incision.
Yeah, we
I
looked
think
at
that
that.
was definitely.
We looked at
Go
that
ahead,
same
Pete.
topic in our own lab and demonstrated with H2O2, and I couldn't agree with you more. That's it's such a great idea that Sethi had to begin with, and such a practice, like a simple change you can make to your practice that could make a palpable difference in infection rates.
Yeah, the second I saw it, I actually emailed Joe Wilson, who's a young member of ASES. I don't know if you know him, but Joe basically took over my practice when I stepped down. And I said, and I also sent it to Grant Garagos, who was at Duke, because Joe and Grant and I would work closely together. And I said, you guys need to start using this. This is something that may be a game changer. And I think it has been a little bit of a game changer. We don't have numbers on whether this has decreased infection, because you guys both know the infections are rare enough that to try and get numbers, you'd have to have like 100,000 patients in the study, or maybe 50,000 or something like that. And you just can't do that study, but it definitely decreases the bacterial load on the skin.
Absolutely. I think that is a very easy practice changer, as Pete was mentioning, and one of the things that makes looking at literature in real time so important. And it's important that we have journals like this, like JACS, that allow us to see those articles hot off the press and get them published quickly. So turning this question a little bit in a different direction, as opposed to what you think is, or what you thought is your favorite article over the last 10 years, is there another article that you think has been the most important article or the most impactful article in JSCS over the last 10 years or so?
I'm not sure I could say, a single article, but, my 10 years has definitely been the era, of the reverse shoulder arthroplasty. And, so many of the articles, showing how well the reverse arthroplasty has worked have been so important. I'm pretty much of an old fossil, unlike you two guys, but I'm old enough to remember in the 70s and 80s we had constrained shoulder arthroplasties, and they were terrible. They were all taken off the market because there were so many complications. So I was a little adverse to trying a reverse when I first heard about it. I had so many patients that could use it with cuff tear arthropathy. But we did other things to try and help them. It wasn't as good. And I still kept being adverse to it a little bit when people said, well, we're going to use it for fractures instead of hemis, because I did fairly well with hemis in that situation. But, the literature is really borne out that these do well. They help people. And in fractures, it definitely looks like they, in general, do better than hemiarthroplasties for proximal humeral fractures. So I think all of the articles on the reverse shoulder have really changed the way we practice shoulder and elbow surgery.
Yeah, that's probably been the biggest change in shoulder generally over the past 10 years. And it's always nice to hear when someone's an editor, they feel like that maybe they played a part in some big change in our practice that that's really helped our patients. It's also remarkable to hear you say that you felt like you did pretty well with Hemis. I think you must have just been better at them than the rest of us.
Well, we didn't have an option, and they didn't do badly. And actually, I did a few reverses for fractures before I stopped practicing, but I still continued doing Hemis almost right to the end. In general, if you look at it, I think a well done Hemi that gets a good result actually does better than a reverse. The problem is that a poorly done Hemi, or one where the tuberosities fall apart, does so poorly that they get no benefit at all to the procedure, and then they end up getting revised to a reverse, and that's been shown not to be as good as a primary reverse. So uh, I wouldn't say I was better at it than you guys, but of necessity, we had to do it. And, I had failures. I can remember patients where the tuberosity just completely fell apart. And I'm like, looking like an idiot talking to the post-op. But the reverses definitely helped.
Yeah, I mean, I think one of the interesting things there is, and this has been shown in papers published in the journal, is that even a reverse, if the tuberosity doesn't heal, doesn't function as well as if you can get the tuberosity reduced and healed. Um, so it's interesting to hear your perspective on that and the way things have changed.
We did a lot of things that you guys may not even have seen when you were doing your fellowships. I know you both did fellowships with Tony Romeo, who's just a tremendous shoulder surgeon. And, we did things like we changed the version. We pointed the humeral component away from the direction of instability. The instability always on cuff tear arthropathy always wanted to be anterior, so you retroverted them more. We put pec majors up there over the top of the subscap when there was nothing there to try and support it. And I even did a few, maybe about 3 or 4, where we actually rebuilt the coracoacromial ligament with an Achilles tendon allograft, wrapping it around the coracoid and then putting it up through drill holes in the acromion, making it. Dave Dines and I were actually talking about writing this up around 2005 or 6. And then, like, about 2 years later, we realized, nobody's going to do this anymore because now we have reverses. So we stopped doing that.
Did you think that it worked?
Yeah. Work is a relative term. It worked in that it didn't, it prevented anterosuperior escape. They didn't get much motion.
Yeah.
But I'll tell you the worst case of cuff tear arthropathy I ever saw was a woman that had been done. I was in the private group in town. The woman had been done at Duke, and it wasn't their fault. Just she got horrible anterosuperior escape. She had no cuff, and the humeral head was almost coming out through the skin. And she'd actually gone up to see Cofield at Mayo Clinic in the late 80s, and I'm seeing her in the mid 90s. And she said to me, he said he couldn't do anything. What can you do? And I just sort of had to shake my head and said, I'm not sure I can do anything here either. And about a year later, she showed up in my office, and now the humeral head had eroded through the skin, and I was looking at the humeral head, and I was like, well, I guess I got to do something now. So that's what I did on her. Was I took the component out, retroverted it to point it away, and I reconstructed the coracoacromial arch. And she didn't get infected, and the humeral component stayed in the shoulder as far as I knew.
That's certainly a win. That's for sure. Why don't we take this in a different direction and get to something that might be a little interesting for our listeners. And hopefully there's more and more of you listeners out there, because this podcast is getting better and better. We were wondering, and Steve and I were thinking about this, when you were back on the tour, who was your favorite competitor? Who did you love to play against, or who did you look forward to playing with the most?
Well, my hero in golf was Ben Hogan, who was, as far as I'm concerned, the 3 greatest golfers of all time are Jack Nicklaus, Tiger Woods, and Ben Hogan, and I sort of favor Ben. I met Hogan once, but I never played with him. And my favorite player among the big players that to play with was Gary Player. He and I got to be very good friends, and I played with him quite a bit. I grew up playing as a junior and an amateur against Ben Crenshaw. Ben and I are the exact same age within about 2 weeks. And that didn't usually turn out well for me. but I enjoyed playing against Ben, and because he was so good as an amateur. He never turned out to be quite as good a pro as he had been as an amateur.
Well, it sounds like you guys had some good times out there. Any specific memory that you can recall that that might be something that us amateur players wouldn't really know about?
Well, the thing, Rachel, I give talks around the country, or I have. I'm getting asked to do less and less of them now, but I would give talks to various doctor groups about the Pro Tour and what it was like. And what I'd tell them was, it's just like the NFL and the NBA, and people don't always imagine that. You take a high school player, for him to move up to the next level at college, it's another magnitude of level up. And to go from college to the PGA Tour is another magnitude again. Those guys are really good. And then to go from the PGA Tour up to the Greg Norman, Rory McIlroy, Tiger Woods is another magnitude in itself. And I made the leap, all the way up to the PGA Tour, but I couldn't get through the last one to get up to the top players. Those guys are just so good. And people don't always realize that because, a lot of people play country club golf and they think, well, yeah, I got a guy who plays pretty good. But it's the same as in the NBA and the NFL. You see these great college players and they just can't cut it in, the NBA or the NFL because the pros are so good. I won over 40 tournaments in my career, and I just wasn't good enough to make it on the PGA Tour at the top level.
Well, certainly at high level for any of us, and it's unbelievably commendable to be at the top of your game in so many different fields. And it's just so intriguing and interesting, and I'd love to pick up some pearls and pitfalls, not only in shoulder and elbow surgery, but also on the golf course with you at some point. I'm sure Pete would too.
Yeah, absolutely.
Well, in terms of your careers and young surgeon's career, I had the good fortune a couple weeks ago, and also sad fortune, to be at the memorial service for John Fagan at West Point. You guys probably know of John Fagan from his sports career, although or sports medicine career. He wasn't really a shoulder surgeon, but John was one of my mentors at Duke. And John told me something when I was a chief resident. We were going to an away clinic, and he said, Bill, when you get out and practice, he says, pick the society that means the most to you and just focus on that one. Don't try to be a member of every society and do everything in every society. And he said that way, when they need a volunteer, you can volunteer. When they need something done, you can say yes. And, I wasn't in an academic practice completely, although I had residents and fellows from Duke. But, the only reason I got to be an editor of the journal and got to be president of ASES was I just focused on the one society like John told me to do. And I kept saying yes. Whenever they asked someone to do something, I would do it. And, Bob Neviser finally picked me to be an associate editor of the journal. And I asked him why he did that. And he said, because you never turned down a review. He says, you always did them. And, I became an associate editor because of that. And then I applied for the editor-in-chief and I got that. But that's all because of what John Fagan taught me.
It's, but I think it's the lesson that you must focus to succeed is a useful one, and certainly something I still have a lot to learn about, to be frank. It's an interesting lesson coming from someone who's had kind of lived three lives. I mean, when I read about what you've done, it sounds like you've succeeded in three completely separate fields. It's almost like you've lived three lives. I mean, it's remarkable. So what have been the lessons you've learned? Like, how does that fit in with what you just told us about focus? Like, what are the lessons you've learned about succeeding in different areas?
Well, they were all at different times, although the Olympic stuff has kind of overlapped my medical career, but it's certainly secondary to my medical career. I wasn't pre-med in college. I didn't go to Duke to become a doctor. I went to Duke to become a professional golfer. That was my focus. I remember freshman week, I was walking on the quad with some guy, and he just said, "What do you think you want to do after college?" And I just said to him, I said, "I'm going to play professional golf." And he just looked at me and he said, "Yeah, right." And that's what I wanted to do. So, that was separate. Then when I realized I wasn't quite good enough to make it at that level, I had to do something else. So I'd been a math and physics major, and I was good in science. So, and I'd already had 2 shoulder surgeries. So I started talking to the orthopedist that operated on me, and I decided to try and go back to medical school. It wasn't easy. I had to go back to school for a year to get into med school, and I had 2 deans of med schools tell me there was no chance I would ever get into a med school anywhere in the United States. But somehow or another, I pulled it off.
Sounds like you proved them wrong, to say the least. What of the different things you've done, what's been the most rewarding to you? Like, what are the things you've done that you'd say, God, I would do that again in a heartbeat? And what are the things you've said, God, like if I could do it again, I'm not sure that was worth the time?
Well, if I could do it again, I would definitely um, go back to med school and become an orthopedic surgeon. The story I tell about that, the last few years, I've been fortunate because of my position as the editor and the president of the society. I've been invited to be the graduation speaker at orthopedic graduations. And the message I give those people finishing is, don't do this for money. Don't go into orthopedics for money, because you'll make plenty of money. It's not going to be a concern for you. Don't be a money grubber. We make a lot of money, and I don't like people who always worry about like what the patient's insurance is. Just do the right thing and take care of them. And my favorite story from that, I tell them, I said, here's the story of something you'll never get paid for, but I never would regret. I was on call back in the early 90s, and I was at one of the away hospitals that we did, a small one doing something, I can't remember what. And the Durham hospital called me up and said, I got a 5-year-old kid here with a completely displaced supracondylar humerus fracture. And that's the type of thing, our sphincter gets very tight immediately. And I was about a half hour away. And the resident called me and said, oh, yeah, he doesn't have a pulse either. And I'm like, oh, great. So I flew on back down to Durham. I actually called the hand surgeon at Duke, and I said, I'm going to take this to the OR and reduce it and pin it. And if the pulse doesn't come back, I'm shipping him across town to you. And I get to the ER, and I meet his mother and father. His mother's a pretty blonde school teacher. His father's this guy, looks like he could have played pro football. He's a Durham police officer. They're just like Ward and June Cleaver. They're the nicest people you could ever meet. And I took the kid to the OR, and we reduced it, pinned it, and of course the pulse came back. He was fine. We kept him overnight. And about 17, 18 years later, I was in the checkout line at PetSmart, and this woman ahead of me, I didn't recognize her at first, turned around and said, Dr. Mallon, do you remember me? She said, I'm Brad's mom. And it was the blonde school teacher I had met with Brad. And she said, he's doing great. And he said, he just graduated from Appalachian State where he played on the baseball team. I said, oh, yeah, what did he play? She said, he's a pitcher. And I just kind of thought, and I said, which arm did he pitch with? And she smiled and she said, the one you fixed for him. And I just said, I couldn't have felt any better. And I tell the residents graduating, I said, you'll never get that doing something else. And all the money in the world wasn't going to make me feel any better than I felt that day. I'd gotten this kid's arm. This is, as you guys know, you can lose a hand in that situation. And he not only kept his hand and did well, he got a college scholarship to play baseball and pitched with it.
God, what an incredible story,
Yeah, it was amazing. I love that story. It was so fulfilling.
Yeah, I mean, I think that's one of the things that keeps us coming back, at least for me, is that the patient who comes back to clinic and says they're doing better. I mean, that I think is way more valuable than any amount of money you could get. It's this job, and the highs are high and the lows are low for sure.
Yeah, and what I tell the residents that for, I said, if you really wanted to become a millionaire or make fortunes, you could go to Wall Street or become an investment banker, because every one of us who was a pre-med, which wasn't me, but you guys, was certainly smart enough to do that, and you could make a lot more money doing that if you don't go to jail. But we're doing this for a different reason, and that's what I try to emphasize to the residents, that we're doing this for those moments at PetSmart where the mom tells you her son's been doing great and finished college with a baseball scholarship pitching with the arm you fixed.
It's also so telling, I think, about the nature of medicine, where if you can be in the same place for a longer period of time, you can really see and reap the benefits of the good you can do for a community. And I think it's so telling too that it was for you. It was that a lot of that's about your community and the thing you did for someone in your community.
Yeah, that's true. If you can stay in one, someone else told me one time, says the secret to having a successful orthopedic career is have one job. Don't be one of those people who've had 4 or 5 jobs and keep switching. He says, you never get established. Nobody really knows you. By the time I finished, all the nurses in town, even the ones at Duke and at UNC, knew me, and I was getting a lot of referrals from a lot of places to do shoulder stuff that nobody else wanted, and some of it was really hard stuff, and maybe stuff I wouldn't have wanted either. But that's how you get your reputation, is to take the stuff that no one else will do.
Well, and it's such an interesting difference from the way that a lot of the statistics are going about people taking a job and then 50% of people changing within 2 years, and us being on a more employed model and being seen from an administrative perspective as more movable pieces. You wonder how that will affect in the long term our job satisfaction, to reduce the number of instances we'll have to have that encounter you just described.
Yeah, I was fortunate that I picked a good job. And the way I picked it was when I was a resident at Duke. The residents at Duke for a long, long time, they don't anymore, but used to rotate with our private group at the private hospital in town. So I knew all the guys I was joining. I'd worked with them. I knew what they were like. I knew they were a good quality group and they were good guys. And you don't always get that. You can't always pick a job where you know the people really well. It's a little bit of a crapshoot for some people, more than what I had to deal with. I was very fortunate.
When you talk about why that was a good job, it's interesting to me that you highlight that you knew the guys. Do you think that knowing your partners, that's the partners are the most important part of the job? We talk about this all the time when we talk about, if you pick a job, you can't get everything you want, for instance.
Yeah, I mean, when I joined the group, I was the 6th surgeon in the group. My former group now has 135 MDs. It's amazing what it's become with all the mergers and everything that has gone on. And I knew all 5 of them. I had spent 2 full rotations, 6 months with them when I was a Duke resident. So I knew there was one guy who was a little ornery to deal with sometimes, and the other 4 were great to deal with. But even the one guy who was ornery was an excellent orthopedist. And it turned out he had a heart of gold once I got to know him better. So, he just has kind of a gruff exterior. But, when you go out for a job interview, in some other state, like if you want to go back to your hometown or something, you don't really know the guys like I did. It's very helpful.
Yeah, it's just interesting to me. I mean, we have a lot of discussions with fellows about, when you pick your job, you can choose if you're going to make a lot of money or choose if you're going to live exactly where you want to live, but you may not get the partners you want. It's just fascinating to hear from you about, just because I think all that fits together. I mean, it fits with this, what you started with the story, fits with staying in the same place, fits with getting the job. It's just an interesting story, an interesting perspective, I think, on a career.
Yeah, the one thing I do tell residents, Peter, and I don't know if you were a resident at Rush or not, but I usually tell the residents, don't do your fellowship where you did your residency.
Yeah.
Because I was about as much of a, what everybody calls a Duke we, as in Duke we do this, at Duke we do that, because I went to college, med school, and residency at Duke. And then I did my fellowship with Rich Hawkins up in Canada. and it was great. I got up to Canada. He did everything. I wouldn't say everything, but did a lot of things different than what I'd seen at Duke. And I started realizing, like, there's more than one way to do this. It doesn't have to be done the Duke way all the time. Just like it doesn't have to be done the Utah way or the Colorado way for Rachel or the Rush way for Tony or Grant Garagos. There's a lot of different ways to do these things, and most of them work. But you get exposed to different things. You learn different ways to do things. That comes in handy sometimes. You're doing something one way that you've always done it, and it just turns out very badly. And if you know another way to do it, you can sometimes have enough experience to turn that around and use the other way and maybe salvage the case.
Yeah, I could not agree more. I was a resident at Rush and then a fellow at Washington University in St. Louis with Yamaguchi and Keener, and it was so valuable for me. I could not agree more. I mean, I did it at some personal. I mean, I had to be apart from my wife for a year, and that was hard for us. But I think it ultimately will have been worth it. Certainly, I couldn't agree with you more that the variety of training gives you a larger toolbox in the operating room and in clinic.
Yeah, absolutely. It also, I'm not recommending everyone do this, but it was interesting to me doing my fellowship in Canada, seeing the Canadian healthcare system, because it is different than the U.S. and seeing how that operated. And it operates fairly well, except for the waiting times to see patients. My favorite story of that was I asked Hawk in the middle of the fellowship one time. I said, Hawk, the books always say if you've got impingement, which was a bigger deal back then, you should wait 6 months, PT, injections, and, don't even consider surgery until they've gone through 6 months of conservative treatment. I go, do you think that's always true? Is what I said to him. And he just kind of laughed. He says, well, I don't know, Bill. He says, I never get to see anybody till they've already had the problem for at least a year because it's so hard to get into the Canadian system to see. So by the time they saw him, they were ready for surgery.
Yeah, I mean, I do. I agree that it's interesting to see other countries give something. It's a similar idea. It certainly gives you, there's cultural differences in places that I think can give you insight into what is pathology versus what is our cultural expectation for the way things should go. That it doesn't necessarily have to be that way.
Yeah, if you ask Rich Hawkins, which I have, what's the biggest difference between practicing in Canada and practicing in the U.S., he says the American patients are just so much more demanding. They want more. They expect more. They expect more studies. They expect more tests. They expect better results. In Canada, it was very much kind of the old, almost family doc system where you tell them something, they'd go, "Okay, doc, you're the greatest. That's what I'll do." And in the U.S., they show up with the 34 sheets from the internet and tell you they know everything about it, and this is their fourth opinion, and they're not happy if you don't make them 100% better. I had what I thought was a pretty good answer for that, Peter. I don't know, maybe you'll want to use it, but when patients would say to me, when we were getting ready to do a surgery, in the pre-op evaluation, I'd say, "Can you make my shoulder 100%?" And I said, I'm pretty good at this, but I'm not as good as the guy who built the shoulder in the first place. And as you know, the shoulders are rarely 100%. I mean, they may be close, and they may be very good, but once you've got pathology, there's scar tissue and other problems in there.
Yeah, I mean, I think that's a great. That's a nice way to put it. I often tell people it's going to be better than it is now. I don't know if it's going to be normal. And I asked that question, that same patient that you talked about, is the shoulder 100? And I think it's hard. There's very few procedures I think we do where the patients come back and the majority of them say their shoulder is 100. I think that's pretty uncommon.
Yeah, maybe taking out a lipoma.
Right,
like
right.
That. But rotator cuff, which is my favorite topic in the shoulder, it's hard to make them normal.
Right.
And Jimmy Andrews and I were talking about it one time. You always read in the newspapers about some baseball pitcher who, has a torn rotator cuff, and Jimmy said they're rarely actually torn. And Jimmy said a torn rotator cuff in a major league pitcher is a career-ending injury, pretty much. Because of the stress they put on their shoulder, it just can't take it anymore.
Well, he once told me that he had more pitchers that returned to play when he treated them without surgery than he was treated with surgery with that injury. So I at least
Yeah,
from him, I learned that you don't operate on that in a pitcher.
yeah, that's true. And you might know Tommy Noonan, who's at Stedman Hawkins Denver. He's actually Rachel's partner.
Yeah,
Um,
yeah.
Tommy was a Duke resident. I helped train him a little bit, and then he did the Stedman Hawkins Fellowship. And he's the team doctor for the Colorado Rockies. And Tommy said, if you talk to a major league pitcher about shoulder surgery, they'll run out of the room because they do not want it, because they know what the results have been like in all their associates.
Yeah, they know the story. This is about all the time we have for our podcast. I can't tell you how much I appreciate you having this conversation with us, Dr. Mallon. This is incredibly valuable. It's I've been a huge fan of your work with the Journal of Shoulder and Elbow Surgery, and I can't tell you what a contribution you've made to our career and to all of our patients. So every doctor out there who's read a paper and that's changed their practice, you've played a part in that, and that's such an incredible gift to the rest of us and to our country, really, and to the world in terms of treatment of shoulder and elbow pathology. So for all of our shoulder and elbow listeners out there, don't forget to subscribe, and we will see you next time. Thank you.
Okay. Thank you, Peter.